The diagnosis of DKA. Is there any way it can be missed in a patient?
If the sugar level is nearly normal, like 160, 170 or 180, the patient can still be in diabetic ketoacidosis.
When the pH falls, a lot of doctors are tempted to use a bicarbonate. What are your views on that?
There are certain indications when you should use bicarb, particularly in the setting of diabetic ketosis, not before that. If the pH is below 6.9, so that is a life-threatening pH.
The first line of treatment, when we talk about treatment now, is fluids. Are there any pitfalls over there?
When you get the patients of diabetic ketoacidosis, initially if you check, there will be around 6 to 10 liters of fluid deficit in your body. So the mainstay is always fluid. For the fluid resuscitation, the best solution will be to give crystalloids, and we prefer normal saline, that is 0.9% sodium chloride.
Welcome to another episode of Santosh Medcast. I'm your host, Samragyi, and today we will be discussing a life-threatening condition called Diabetic Ketoacidosis, or as all the doctors call it, DKA. Today we have with us Dr. Debapriya Sarkar, Critical Care Senior Consultant at Santosh Medical College and Hospital. How are you, sir?
I'm fine, thank you.
Okay, so let's dive in.
Yeah, sure.
Yes. So the first question we have is very basic, but it is very critical. The diagnosis of DKA. Is there any way it can be missed in a patient?
Yeah, this question is very pertinent, I'll just start with an example. That a couple of months back, we received a young patient. He was only 35 years old, posted for elective surgery. But that surgery got postponed, because he was having this severe pain, abdomen and vomiting and all, and he was shifted to the ICU. And he was a diabetic patient, and but his sugar levels were normal. It was around 165 or something like that. Now the thing is, still this case was diagnosed as a case of diabetic ketoacidosis. The crux. Most of the times, most of the clinicians or the junior doctors, they tend to believe that diabetic ketoacidosis means the sugar will be very skyrocketing. It will be very high. Even if you go through the book's definition, it will be like 400, 450, 500. Sometimes that your glucometer will show you a high reading, but it is not a factual thing, because in many conditions, even if the sugar level is nearly normal, like 160, 170 or 180, the patient can still be in diabetic ketoacidosis. Particularly in my patient, he was a diabetic patient and he was taking this SGLT2 inhibitors. Probably he was taking this dapagliflozin, right? So in these patients, you can get a normoglycemic condition, like there is a euglycemia. So you can get a euglycemic diabetic ketoacidosis, particularly in this kind of patients. Sometimes that in particularly pregnant patients, okay, the sugar level may not be that high because the metabolic demands of the pregnancy is very high. So in a lower threshold like 170, 180 level, you can get diabetic ketoacidosis. Now just now the Navratra is over, so during that time people do all these fastings. So particularly fasting is not advisable for diabetic patients, but during these fastings the sugar level may be normal, but those patients also that can lead to this diabetic ketoacidosis, fasting or starvation. So my point is that yes, diagnosis can be missed sometimes, but you should not rely only on the sugar level. You should always check the ABG to see the acid base status of the patient, to see the bicarbonate level of the patient, or to see the blood ketone level of the patient. And obviously if you are seeing the ABG, so obviously you have to interpret it the anion gap also. In diabetic ketoacidosis, you will get a high anion gap metabolic acidosis. So yes, sometimes it can be missed, but you should have a high degree of suspicion for that.
So I would like to follow up this ABG question. So when the pH falls, a lot of doctors are tempted to use a bicarbonate. What are your views on that?
Yeah. So that is a very common temptation, that in our ICU also, we sometimes, when the junior doctors like postgraduate students, they are posted, they'll be very tempted that the pH is 7.1 or 7.2. Should I give, that 100 milli equivalent of bicarb stat followed by some bicarb infusion? This is an absolute no-no. So there are certain indications when you should use bicarb, particularly in the setting of diabetic ketoacidosis, not before that. Particularly if the pH is below 6.9. So that is a life-threatening pH, because we tell that the pH of less than 6.8 or more than 7.8, those are not compatible for life. So if the pH is below 6.9, definitely you can use bicarb. Or if the metabolic acidosis is so severe that there is a severe cardiovascular compromise, the BP is also very low, the patient is hemodynamically not stable, and the pH is very low, like 6.9 or something like that, you can use bicarb. But most of the conditions, bicarb should not be used as the primary management, particularly in DKA patients. If you are getting even a pH of 7 or 7.1 or 7.2, something like that, because bicarb is a double-edged sword. It can correct your pH, but the problem is that it can give rise to this cerebral edema, particularly in younger patients, like in kids. Or it can delay your recovery also. So the standard recommendation does not give us permission to use bicarb in diabetic ketoacidosis patients.
Okay. And so the first line of treatment, when we talk about treatment now, is fluids. Are there any pitfalls over there?
Yeah, so fluid is the mainstay of diabetic ketoacidosis management. See what happens when you have a very high sugar level. See, sugar and water, they are like friends. They're bonded. They're
Best
bonded
friends.
couples. Yeah. So whenever the sugar moves, water tends to follow it. So you can remember the diabetic triad. There is a one component that is polyuria. Okay, so most of the times there is polyuria and lots of water is going out of your body, and there is lots of dehydration also. Okay, so the thing is, even when you get the patients of diabetic ketoacidosis, initially if you check, there will be around 6 to 10 liters of fluid deficit in your body. So the mainstay is always fluid. Now the thing is, there are two pitfalls. One, what to start, which fluid we should start, at what quantity should we give the fluid, and to what to avoid. Okay, so there's some balance that you have to maintain. So obviously for the fluid resuscitation, the best that solution will be to give crystalloids, and we prefer normal saline, that is 0.9% sodium chloride. That is a isotonic fluid that you have to give. Second thing, that that you have this deficit of around 6 to 7 liters, but you should not try to correct it within the 1 hour or 2 hour period. So initially for the first hour you should give around 1 liter of fluid. Around is roughly around 15 to 20 ml per kg of body weight fluid bolus that you have to give. The second thing is, and simultaneously you are starting all this insulin and everything. Second thing, so the first choice is 0.9% sodium chloride. Second thing is 15 to 20 ml per kg body weight. Sometimes we miss that. We start with a maintenance fluid of 100 ml or 150 ml or 200 ml per hour. So that won't do, because we have to do the aggressive fluid resuscitation. Second thing is the choice of fluid. Most of the clinicians, they should use that 0.9%, but some clinicians, if they see the sugar level is around 250 or something like that, they tend to change it to the D5 or any hypotonic fluid. That should be avoided. That should be avoided until and otherwise the blood sugar level is below 200. You should not change the fluid from normal saline to any dextrose containing fluid, be it D5 or be it the DNS or whatever. So the choice is always and always normal saline till the sugar level is around more than 200. If it is below 200, then you can switch. So this switching, that is a very important thing.
So euglycemic conditions are when we should be switching.
Yeah, like 200 or something like that. But because in a critical, we are not targeting, particularly if we are treating a DKA patients, we are not targeting to a sugar level of 120 or 80 or 100, something like that. So if it is below 200, it is acceptable, because you have to give the insulin. So now there can be the chances of hypoglycemia and all. So you have to switch to the D5 or any hypotonic fluid of your choice, dextrose containing preferably.
So you said my favorite word, insulin.
Insulin.
Insulin is the backbone of diabetic ketoacidosis treatment.
Yes.
So what is some mistakes that the clinician can make while administering it then?
So what happens when, just like bicarb, your previous question, that When the pH is around 7 or 7.1, something like that, people tend to use the bicarbonate infusions. Now, if you get a patient of diabetic ketoacidosis and his sugar is very high, around 400, 450, something like that, obviously you'll be tempted to use the insulin. And insulin, we give the IV insulin, not subcutaneous insulin that we give in the diabetic ketoacidosis, because we need fast actions. Okay. So you need to give insulin, that too in a continuous infusion dose, right? What happens? We have to see the potassium level before starting the insulin. Because what happens, insulin, as we all know, that insulin, that pushes this potassium back into the cells.
Yes.
So there will be intracellular shift of the potassium when we'll be starting the insulin. So you have to see, you have performed the ABG or you have sent the electrolyte samples. You have to see what is the exact potassium level of that patient. If it is below 3.5 or 3.3 or something like that, before starting the insulin, you have to give the potassium replacement. Otherwise, what will happen, that you will start the insulin, all those potassiums, there is already a hypokalemia. Though in metabolic acidosis scenario, there should be hyperkalemia. So that is one warning sign, that if you are getting hypokalemia in spite of that severe metabolic acidosis, so that should ring a bell in your brain, that that something is wrong. Now, if still you are getting a hypokalemic condition, first try to correct, give some potassium. Otherwise, what will happen, all those potassiums will shift intercellularly and there will be severe hypokalemia that will lead to your arrhythmias. So one thing is that before starting insulin, you have to always check the potassium level. Without seeing the potassium level, please don't start the insulin. You prepare everything, but please see. Next thing is one more thing. One more thing is that, that whenever you are getting suppose you are getting a sugar level of 180. Now what you will do? You will stop the insulin or you will continue with the insulin, or suppose 150. So you should not. See, our target is not, to just lower the sugar level. Our target is to correct the acidosis. So until and otherwise the acidosis is corrected, the bicarbs values have reached their normal and the anion gap is closed, you have to continue insulin. So even if it is around 150, 160 or 140, you start with the dextrose containing fluid and you simultaneously continue with the insulin. So that is the thing. And don't switch to the the subcutaneous regime so early. Until and otherwise, all the metabolic parameters are normal.
Sir, such critical patients, they require a lot of monitoring, even though a lot of clinicians see it as a background task. So, is there anything that we should be focused on when monitoring patients?
See, most of the DKA patients, the dictum is that DKA patients should not be managed in ward. They should be, the transferred depending upon the severity. If it is a mild DKA, they can be managed in a high dependence unit. But in the most of the cases, they will be shifted to ICU. So now ICU, all the gizmos are there. That all the pulse oximeter, BP and everything. Everybody is so concerned about all these monitorings. But what people tend to forget, that other monitorings are also there. Okay, now you have checked sugar. Sugar once, then you have started the insulin. Now what? You have to check the sugar hourly, because our target is to decrease the glucose level around 25 to 40 milligram per deciliter per hour with the insulin infusion. Now you have to check for the sugar level each and every hour, and you have to titrate your insulin doses according to that. Second monitoring thing comes serial ABGs. So serial ABGs, like you have started, so after 2 hours you have to repeat the ABG to see that whether your acidosis has improved or not, your bicarbonate levels have improved or not, or your anion gaps is closing or not. Third thing that you have to monitor is the electrolytes. There is a sodium, because you are giving so much sodium chloride, and you also have to see the potassium that we described. No? So for every 4 hours, the book recommends that every 4 hours you should send the potassium sample, sodium sample of this patient. So you should not miss that. And the last thing is that is ketone. Now in ketone, actually, you have to see the blood ketones. Most of the people try to see the urine ketones. See, urine ketones, even we detect the urine, you will get only acetoacetates. So that is not a reliable thing to do. If you want to check, you have to check the blood ketones. That is basically beta hydroxybutyrate. So you have to check that. So you know that if you tend to monitor only the urine ketone, that won't be sufficient, because that lags behind all the clinical things. So four things that I want to emphasize. First thing is regular sugar monitoring, hourly sugar monitoring. Second thing is that you have to send a 4 hourly, that electrolyte samples. Third thing is the serial ABG monitoring, and the fourth one is the ketone, along with all the vital parameters that you are monitoring for the patient.
So, sir, is there a reason why a ketone test may come out positive, but the patient doesn't exactly show symptoms of ketoacidosis?
Pardon?
Uh,
Ketone test? Yeah,
is
sure,
false
sure, sure,
positive.
sure, sure, sure. Yeah. Sometimes that your ketones may be positive, particularly in starving patients.
Hmm.
That the patient, if the patient is on a keto diet, or that patient is starving, particularly in the Ramzan months or all, or sometimes that young generations, they're very health conscious, so they follow all these that meals like intermittent fasting, and that different kinds of meals, where they sometimes that I encounter my younger colleagues, that they are only taking some that like chicken or something like that in the morning. After that, the entire day is fasting or something like that. So these kind of starvations, that our body has two types of metabolic pathway. One is aerobic and the second one is anaerobic. So if you are not getting adequate that products for this anaerobic for this aerobic metabolism, your body will switch to the anaerobic metabolism, and there will be the production of ketones in your body. So even if the patient is non-diabetic or is not in a diabetic that ketoacidosis stage, you can still get urine ketone positive. And the second thing is that even if the diabetic ketoacidosis is resolved, in those patients also you can get urine ketone positive. Because what happens in the recovery phase, this beta hydroxybutyrate, they get to convert into the acetoacetate. So after 96 hours also you can get, even after 72 hours, 96 hours, the urine ketone will be positive. So you should not rely on that. You should rely only on bicarbonate, anion gap, and the sugar level. That's all.
And for people who are showing this asymptomatic ketones in their urine, any treatment that they need to do?
No, they should that change their
Change
lifestyle
their
and all.
lifestyle
That is the
diet.
perfect thing.
Okay.
But they
Just
should consult a doctor, because there are other reasons also. So probably there are other reasons also, so they should always consult a doctor why they are ketone. Otherwise, why people will do that urine test for ketone if they are not
so
experiencing
normal
something?
urine analysis.
Yeah,
Or
sometimes. Yeah,
they check
yeah,
it
yeah,
normally and then they're like, oh, oh
yeah,
no.
yeah. That is the thing. Yeah.
Okay. So, sir, what would you say are our biggest takeaways from our entire conversation?
See, the biggest diabetic ketoacidosis, first thing, is a very life threatening thing, what you have mentioned also. But if we detect it in a timely fashion and we manage it accordingly, then the mortality is less than 1%. But it can be 100% lethal and fatal if you misdiagnose it or mismanage it. So I will start from the very beginning. First thing is to diagnose it properly. Even you can get euglycemic diabetic ketoacidosis. So your degree of suspicion should be very high. So even if you are getting a patient of 160 sugar with other features suggesting the possibility of DKA, even if your sugar is normal, you should suspect the diabetic ketoacidosis. Second thing is judicious fluid management. Don't restrict yourself when giving fluid. Obviously, you have to follow some rationality. First hour, you have to give 1 or 1.5 liter of fluid, and according to the body weight, around 20 ml per kg. Okay. Choice of fluid is very important. You should always start with the normal saline. Don't switch to dextrose containing fluid too early. Okay. Then the second is, don't tempt yourself to give the bicarb even if the pH is 7 or 7.1 or something like that. Even if you will be giving fluid and insulin, it will automatically subside. And last thing is that insulin, you have to, before starting insulin, you have to check the electrolytes, and don't switch to the subcutaneous insulin, or don't stop insulin prematurely. And in the monitoring, don't rely completely on only the sugar level. You have to see the acidosis level, bicarbonate level, and the anion gap. Those are the main thing. If you follow this, you can effectively treat a patient of diabetic ketoacidosis.
Thank you so much, Dr. Sarkar. And that brings us to the end of our episode. We
you.
really
Thank you,
hope you
Dr.
had fun. And please like, share, follow, and subscribe Santosh Medcast for our later episodes. Till then, stay sharp and keep learning. Thank you.
Thank
Thank
you.
you,
Thank
sir.
you, Samragyi.